Let's do it. Hey guys, welcome back to another episode of the Altmed podcast. I'm here with my co-host as always, Mitch Kurtz, and we are thrilled to have on the potty today Dr. Zaina Cheema from the Sunflower Clinic, or Cheems, as Mitch likes to call her. How you doing, Dr. Zaina Cheems? What would you like for this one?
You can call me Cheems or Zaina. So whatever carries more affection and warmth.
Yes.
It's that Cheems, actually.
The Cheems. My mistake. Well, the Cheems, I'd be interested to know how you came to be prescribing cannabis, what your sort of background is as a doctor. When you were in med school, were you always thinking about the exciting day when you would be able to prescribe cannabis to people, or is this something that came in a little bit later?
It's a good question. Look, I mean, essentially what happened, the truth is that my son he said, Mum, I want to go live somewhere with coconut trees. And I was like, you know what, babe, it's you and me. Let's do it. So I quit my job in private general practice in Bondi Junction and applied to be the island doctor at the Cook Islands. And it was just coming up to Christmas and I did not get any response back. So then kind of thought, okay, well, I wanted to pivot. So what do I want to do? So I started working with athletes, retired athletes, some amazing individuals who unfortunately had really, damaged their joints by age 45 and were in quite a lot of pain after they retired. And they had come to me asking for a bit of an integrative approach. So obviously we did, all the good nutritional medicine stuff. And then a few of them started asking for CBD oil. And I had never prescribed it at that time, but they'd said, a few of my patients had said they'd gotten it from overseas and it was really beneficial. And when I looked into it, I thought, hey, could be anti-inflammatory, might be worth having a go at it. So that's how I got into it. I can go to my medical school because I think you asked like 3 questions there.
Yeah, sorry. I usually bundle quite a few in, but just to clarify, so you didn't end up going to the Cook Islands?
No, they didn't accept me.
Oh, God.
I feel like it was some bureaucrat who let it slide and like a few months later was like, whoops.
Yeah, totally.
Doctors there.
Are there any other like coconut bearing islands that we were under consideration or?
Coconut bearing islands.
Back to the second part of your question, Andrew, because in medical school, I always wanted to work with Doctors Without Borders, right? So I always saw myself as living in, remote, non-urban environments. And so that's kind of the space it came from. What I ended up doing then was just doing a lot of remote Australia work in, Broken Hill and Forbes. And I was flying out every second week doing the emergency stuff then. But with my 6-year-old, that kind of, that's a whole other thing. I'd like to maybe touch on how locums can kind of help close the gap in service delivery in Australia.
Well, let's jump right into that because that is a fascinating topic. And I have to say that, from my limited knowledge about it, I know that they try to incentivize young doctors to go out to these rural parts in Australia, but the uptake, I'm told, is still, there's always a need. What was your experience like? What kind of communities were you serving?
Yeah, so look, it's a very complex issue. So in terms of the feeder into it, so if we're going to break down the issue, so when kids go to medical school, there are certain programs like scholarships and rural streams that will pre-select people that are likely to go on and do longer term work. I went to Western Sydney Uni and we had this amazing initiative where we got to choose to go to Lismore or Bathurst for the year. I think it was in 4th year medical school. And I was like, yeah, cool. I want to do rural work. So I'm going to do that. And that was very useful. But my GP mentor, my country mentor, absolutely amazing guy. And this gives you an idea of what country doctors really do. So he would be running the anesthetics at the hospital. And then he'd be flying out to Kununurra. He would be, running a GP practice. He'd be teaching us. His skill set was so broad that he could administer anesthetic for a C-section or a trauma patient. And he had, I don't know if he did a pubic symphysotomy. Now that was very impressive for me. What that means is when a baby gets stuck, right, you can do a C-section. But when they get really stuck and that doesn't work, and it's like baby's going to die, mum's going to die, there's this really rare procedure where you actually pull the pelvis apart, like surgically. And so he did that. I can see your face, Mitch.
Oh, yeah. I'm not good with this. Probably why I'm not
Mitch,
a doctor.
Mitch, you will never have to have this procedure. Just
the thought of it, though. Yeah, it just needs, I need a high dose of THC. Sorry.
Right. Look, I mean, you can just stop my inner like.
No.
I was just like, oh my God, this is the kind of doctor I want to be. But what he said to me, because I was kind of torn between, look, I've grown up in Sydney. I don't know how long I can live in the country and do this amazing work that I'd want to do. And he said, the future of bridging the gap is more urban doctors taking up locum roles. So you just basically, you partner up with a GP in Forbes, and you say, hey, you know what, you can go and have a Chrissy break, and I'm just going to cover you for those 2 weeks every year. Or you set a time, and that allows our rural workforce to get some relief, right? And some regular, support. And the other thing is telehealth. Sorry, the problem with recruitment, right, is recruitment is done through recruiting agencies largely, right? And what they're doing is, I'll give you an example. So when I was recruited to go and run the emergency department in Broken Hill, I was on the phone and I was like, okay, so I have trained in a major trauma center, but that's been supported by lots and lots of people. What am I going to be required to do? And the person on the phone couldn't really tell me anything because they weren't medical. So when I was speaking to my colleagues here, they were like, Broken Hill, they're like, you can't go out there and do emergency there because you don't have the skills of an emergency specialist. And for a while that did put me off, but I realized then that, yes, of course, they're absolutely right. I'm not an emergency physician, I'm a GP, but only 15% of our emergency departments in Australia have an emergency specialist. All of the rest, so 85%, if my math's right, are run by health workers, nurses, GPs.
Yeah.
And that kind of, that kind of flows into my approach to Sunflower Clinic, which I started after I left the ED stuff. We're in the middle of a tsunami. We're at breaking point with the mental health crisis. I don't know if I'm just in this space now, but the amount of youth suicide and really devastating effects on people's mental health that we're seeing post-COVID, and with our general practice and psychiatric system being overwhelmed is quite immense. And I think what I learned from that is that GPs who may not be comfortable like running an emergency department sometimes have to do it when they're in a crisis situation. And I would also say that I'd encourage more GP colleagues to really take that step, be uncomfortable, but know that, something is better than nothing.
Yeah, absolutely. It's a really interesting point you raise, because I think that there's a tendency for people to maybe either be boxed in by their institutions or even by themselves. But, doctors effectively come out of med school, they might pick a specialization, which I know GP is itself a specialization. And the idea that, as you described this guy going to Kununurra and doing this crazy emergency procedures, this is, I guess people are more prepared to, because they have to take on more responsibility and broaden their skill set, and become the ultimate generalist, really, by having those experiences. And so, I guess thinking about that in the context of the mental health crisis, if we only have the scope of each person's role in that mental health system being, rigorously defined and being sort of immovable, then, from the patient's perspective, I'm guessing they sort of just get passed around between crisis assessment teams and then, triage nurses and all of this. And it is more useful if we break down a lot of those barriers and people are prepared to expand the scope of healthcare services that they provide. So, and it sounds like you've really hit your straps in that respect following your locum experience. So that's really wonderful.
Yeah, no, I agree with everything you said. Yeah, totally.
I'm curious, just because it's something that I've only recently started to learn about, but this idea of bush medicine, is that anything that you encountered on any of your trips out into some rural parts of New South Wales or elsewhere?
Do you mean as in primary response, like treatment on site of like tractor victims or stuff like that? Do you mean pre-hospital medicine?
Yeah, so pre-hospital medicine. I'm just learning more and more about.
Or do you mean how like cannabis grows in a bush?
No, I mean the sort of this idea or this concept of bush medicine in certain Indigenous communities and this continuing use of it. Is that something that you had any contact with during any of your locums?
No, I was very much in the system, right? In the hospital system.
Yeah. Okay.
I'm just curious because I know we've had a lot of different doctors on the show, and we've had some, let's say, older doctors who maybe during their studies and training in medical school weren't really taught about the endocannabinoid system or anything like that. You obviously being one of the younger doctors on the show, was that something that was brought up when you were studying? Was the endocannabinoid system and some of this stuff touched upon, or was it glazed over? Was it not there at all? Was it taught in depth? I'm not sure.
No, so it wasn't taught at all. And the reason for that is what I got told in medical school is that medical knowledge doubles every 7 years.
Really?
Every 7 years. And that was pre like the tech revolution, right?
Wow.
So it's exponential. Number one. Number two, I got told that it takes 17 years for research to translate into clinical practice. And thirdly, the function of medical school is to basically teach you the basic sciences, teach you the skill of diagnosis, and let you understand pathology or disease. That's the function. There's 5 years there, right? It takes 30 years to master something. So no, is the answer.
Okay, cool. I'm glad for clearing that up. So, but what you're saying is, if we take the fact, and the research would be starting to be done in Australia now on cannabis, or it is. But basically, what we've had legalization since the end of 2016, so maybe say 2017, 2034 is what you're saying, for it to become a widespread type of practice is probably the timeline that we're looking at.
Possibly, but what does that mean? Does that mean we're not going to be able to deliver excellent care or have specialists in the field that can scale therapy?
No, I don't mean that. I mean from when you're just kind of, going to your regular doctor and being like, "Hey, doc, CBD," and then they're like, "The hell's that?" No, that's just pot. That's not good. Or not even. Maybe I just have to refer you to somebody who knows more than me. But just like, oh yes, no, we can get you some THC because you're suffering from this type of pain, and we can help you out. Or it could be psilocybin by then. But in terms of cannabis, if you're thinking about that 17-year kind of arc, it's I guess.
Yeah, the 17-year arc is when Didi Miri or somebody in some lab somewhere finds a receptor that is targeted by a cannabinoid and goes, oh my God, this could actually be anti-prostate cancer. Like, for that to actually then get to doctors using it, that's 17 years, right?
Yeah.
That's actually taking science and infusing it into the art of medicine and delivering it to the patient, right? That what we're talking about is awareness, destigmatizing a therapy and coming up with the appropriate referral channels, right? So it's the same as like when you have a patient who you go, this patient really needs, psychotherapy, or this patient really needs to see a gynecologist. I think that's the kind of awareness we're going to have, is like, you come and see your GP and your GP will be like, oh my God, you have chronic pain. Certainly you've got 80% of people with chronic pain will have significant psychiatric comorbidities or stress or anxiety, I think this is definitely a good treatment for you. I can't do it, but 3 of my colleagues in my practice can, or I'll refer you to da-da-da. That's how it'll kind of happen, I think.
Yeah. And I would think just on that 17-year arc, I mean, it's, company makes that discovery in the R&D lab, registers the patents, puts out a publication with preliminary, positive findings about efficacy for that particular molecule to treat this. It's all so conservative. And then, it might be approved on a limited basis to treat to just treat that condition. And then there's the off-label use by, doctors and just that process of PBS catching up to subsidize something for a broad range of indications, I think is what I'm sort of starting to see will be what takes considerable time. And it's further made more difficult by the fact that we're dealing with plant medicines that have multiple compounds. So being able to isolate that a particular compound within cannabis medicine is indeed the active that is creating a good result for someone's condition is made more difficult.
Can I just say something on that point? So I think it's kind of two schools of thought. So in our very, technologically advanced, I guess, modern medical system where we do rely on very targeted advanced therapies against one molecule, yes, we're going to have that problem. But I feel like if we go back and really look at medicine more as an art, I think what we've lost is the art of being a clinician or the art of being a physician. Essentially, you're a scientist, right? And basically, there are four pillars of medical ethics, right? Do no harm, non-maleficence, beneficence, justice, and something else. Oh, and autonomy. And the way I view being a doctor is that is my circle that I practice within. And I do believe that I have the prerogative to discuss with my patient their, issues and their problems and come up with a very tailored treatment plan. And I think that is the way a lot of GPs are moving, a lot of integrative doctors are moving. And the interesting thing about a plant medicine is you can use it in that way, right? You can use it in that way because you're not targeting one molecule. The therapeutic range is broad. The toxicity is low because of that. So I think I went on. That was very convoluted. My point of, hang on, give me a second. What I was trying to say was with plants, it's actually easier to, it actually gives you more license as a doctor to be creative, right? Mm-hmm. So when I get given a plant, so let's say if I get given, some dried herb, I now am not being told by a pharmaceutical company that this is going to help patient X sitting in front of me with severe osteoarthritis in both legs who can't get up in the morning. So I don't have that told to me. What I do have is I can jump on the internet, I can do a search of the literature, I can read case reports by fellow doctors who've said, 50-year-old woman, severe rheumatoid arthritis, 3-month trial of, whatever, and that helped. So I think what I feel the benefit of plant medicine is there aren't those strict boundaries, right? The strict boundary is keeping your patients safe and reducing suffering, right?
Yeah.
So if you balance those two, I feel like I guess my hope is that a lot of my colleagues would step forward and work in a space where there is uncertainty in that space, right?
Yeah.
But there's also a lot of benefit to patients if we can kind of take that upon ourselves and not practice so defensively and worry about, litigation and things like that, as long as we really focus on the principles of keeping the patient safe, giving them some relief from what they're suffering from, rather than turning them away.
Yeah, I have to, though, just speaking on behalf of all lawyers, which I'm sure they'd be very comfortable with me doing, I feel like there has to always be a role for medical negligence litigation. I mean, how else are we going to keep our profession afloat. Sorry, no, just to
no, I think from that though, it sounds like, and I think this in a lot of times, cannabis toes the line between that kind of Western and Eastern medicine feel, at least the way people, kind of experience it. It's almost like it's got that side of it. We're now seeing that is backed by the literature, and we're seeing the studies come out to support that it's, anti-inflammatory or antifungal or whatever, different antiemetic or whatever the study says on that particular indication. But we've also got this kind of conventional wisdom that's been passed down from generations, like when you got this strange auntie that tells you got an earache, put some garlic in your ear or something like that. Like there's that plant medicine, which is like something that people figured out via kind of trial and error originally. And there might be some merit to, certain compounds in the garlic having X effect. It's not the same as getting a Pfizer-backed drug for sure, but there is something to it, let's say, or like chicken soup when you get a cold or something like that. You know what I mean?
Yeah.
So I feel like it toes that line well. And I think you do find that it has that kind of science meets creative element. I feel, at least the way doctors describe it, almost like I have a background in audio engineering, which is very much, scientific. It's very much about certain waves hitting you at certain frequencies, doing X and Y and Z. But the way you interpret, the way you manipulate those frequencies has a creative element to it. So you can create something that's very different, though you both have a sound understanding to somebody else, though you both have a sound understanding of the science behind it, if that makes sense. So
a sound understanding. Oh, I see what you did there. That was good.
Yeah, thanks. In saying that, I'm very curious where the name Sunflower Clinic came from. Could you
Do you want the honest answer?
No, I want you to lie to us.
No, it's my spirit flower. What can I say? Yeah. So sunflowers basically, they reflect the light of the sun. They, reflect the truth. And my cousin actually had a recurring dream of me as a sunflower. And then I started, when someone says something random to you like that, and then I just started seeing sunflowers everywhere. And I was like, I guess the hippie in me was like, it's my spirit. And like, it makes people happy. So I thought Sunflower Clinic.
Isn't there something also about sunflowers that they turn to each other? I'm trying to remember what that is.
Yeah, I think when the sun's there, they turn to the sun. And when it's cloudy, they turn towards each other.
Yeah. Yeah.
Nice.
It's like kind of like the endocannabinoid. Trying to tie it in.
Yeah.
No, that's brilliant. But I love that. But in more kind of practical terms, you're kind of more geared towards mental health. Is that right?
Yeah. So, I mean, I have a few hats. I still have my GP emergency appointment at Forbes and, to fly out there. And I work also in standard general practice here in Sydney. But what I found was that my mental health patients really needed more care, more time, and I couldn't like authentically step into that space and, help in that problem without creating the infrastructure for that. So standard general practice, it's very hard, not only because you have 15, 20, 30 minutes, but because it's cognitive switching, right? So I'm dealing with sometimes a cancer, sometimes an immunization, and then you have to switch gears and create space while you're running late for someone who really needs your time to work through, mental health struggles. So that's why I started Sunflower Clinic. It's kind of my vision of how general practice mental health care should be delivered. And it's also because I'm an integrative GP as well. I do nutritional medicine there. So everything from I'm a big believer in your physical health impacting your mental state. I think everybody believes that now. And a lot of times I've had patients who basically have been really, really iron deficient or really, really low vitamin D. And it's just made their depression so much worse. I've had a few patients, after having their iron corrected who said it's like life-changing. So what I like about Sunflower is I can do all that. I can do the comprehensive full body medicine. And then, if my patient wants, we can sit there and just do a counseling session. I obviously do, cannabis treatment there as well. So it's like a very free form, tailored boutique mental health general practice sort of environment that I wanted to create.
Interesting.
That's great.
So what I'm just curious, what would a new patient coming to you, what would a typical patient look like? I know you can never say, you as you said, you're jumping hats all the time, but in terms of if you could give us maybe an example of the type of patient you might see, that'd be great.
So I usually see patients who've gone to a lot of different people who don't have a clear diagnosis, but have been suffering, from depression for 10 years, or patients who've had a lot of compounded childhood trauma, and now they don't understand why they're reactive or they're impulsive or why they're irritable. I see a lot of patients who are very high functioning, but have severe debilitating anxiety that they've been hiding for a long time. Some of them are everything from executives to mums to teachers. So I see a lot of people who actually whose mental illness or state is making them quite sick. And I see more of that. I see more people who present with severe depression, severe anxiety. I see less people who are well but just need a bit of counseling. I see less of that. And I think by the time they get to me, I'm seeing a lot of people with bipolar disorder and PTSD. And I think that's what those symptoms are that are kind of coming through.
For some of those patients, you talked about the Hippocratic Oath before. What do doctors make of commonly prescribed drugs for people with mental health issues? I'm sort of thinking here of SSRIs and other classes of drugs in that ilk. When those drugs, which I might add are sort of registered and approved by the TGA and on the Register of Therapeutic Goods, when they carry side effects like this may cause suicidal ideation, or have we got a problem in terms of trying to square that with the Hippocratic Oath?
I think the problem is that for 50 years, in our doctor's bag, we've had like two things, tranquilizers, antipsychotics, maybe benzos, SSRIs, right? So when you are sitting there with a patient in front of you who's suffering, and you only have these three things, what do you do, right? So I think the key is that we really need innovation in mental health treatment. And I think we're there, right? I have some of my patients I've referred for transcranial magnetic stimulation. Some people say that's changed their life. I've seen people going through trials for psilocybin, where there's a resurrection or a renaissance of the psychedelic treatments, which are very useful for some patients. SSRIs and SNRIs are life-saving for some patients, right? But I think we have to use every tool in the appropriate way. And we know with SSRIs or SNRIs, so when I say that, I guess for listeners, that's things like Prozac, the standard, medication pills that you would be told to go on. You'll get an effect after 6 weeks. And the thing is, people are often left on these for life. And what I got taught was that really every 6 to 12 months, you should review that, because major depressive disorder often will lift after that period of time. So if I see a patient and they've been on, a standard, say Prozac, for a year or two, and they're not improving, then I have to think, why are they not improving? Have we got the diagnosis right? And, some people would say that 30% of very severe melancholic depression, I'm talking the people who really are at risk of becoming suicide victims, 30% could be bipolar disorder. Now, I know in my earlier years as a doctor, I didn't really understand bipolar. Perhaps I even projected some form of stigma onto those patients, because I remember as a junior registrar, I remember a patient walking in who had bipolar disorder on like all these medications. And it was confronting, because I didn't actually know how to treat that condition. I didn't know anything about those medications, or even what that condition was. it's only recently I've become aware of the fact that it's actually a neurodegenerative condition. These people will die 10 years earlier than other people, and their mental illness is because of basically inflammation in the brain. It's the sodium channels. It's like rapid firing across cell membranes. And what's happening, going back to that 17-year translation into clinical practice, is I know there's lots of research happening, and people are saying fish oil is very good, all this other stuff is good, but that research is going to take many years to translate into practice, right?
Yeah.
Yeah.
It's a really, as we wait, I suppose I just query why, I guess the medical establishment seems so divided. We've had decades of these drugs being prescribed ineffectually for a lot of people. And we have something like psychedelic medicine, which shows enormous promise, and yet the TGA is still yet to down schedule it to an S8. And I suppose as a layperson, I look at this and I just, I guess I can't understand why the establishment isn't beating down the door for more options. As you say, if you only have 3 tools in your toolkit, which are approved for prescribing, why wouldn't you want to expand that? But then when you talked earlier about how medical knowledge doubles every 7 years, I guess the medical establishment is still made up of a lot of very old school doctors who, might show a reluctance.
I think it's very, very complex, right? So we're talking about human behavior, we're talking about power structures and why there isn't a revolution. And we're talking about technology that maybe doesn't exist. Now, there is no establishment, right? There's government bodies which regulate, as lawyers are regulated or sound technicians are regulated, regulates doctors. So and rightly so. I've seen a lot of rogue practice out there. And so certainly the unique thing about medicine is that patients are very vulnerable. And so yes, doctors are regulated heavily. Now, what the heavy regulation does is it puts a lot of doctors into a position where they don't want to do anything that is going to be outside of the box that they imagine they've been put in. It's an imaginary box, right? Because what happens is a lot of clinical practice becomes robotic. It's like, I learned this drug, this is what I prescribe, this is what I do, because I don't get to think about my problem, right? Because we don't have a system where the government says, you know what, we want our physicians to lead innovation, and we're going to create infrastructure to allow that. We're going to create we're going to create primary care practices where we're going to every week give you an evidence-based report summarizing what in Australia we have found are the new things for mental health. And we're going to give you a list of the practitioners who are providing that treatment, and we're going to compensate that financially. Or the problem is that doctors are in charge of medicine, scientists are in charge of innovation, government is in charge of regulation, and there's no integration of those 3 very important parts. So scientists can't say, oh my God, this is an amazing therapy that can be used safely, Dr. X. Why don't you, for example, if a scientist says, wow, I just discovered in 6 months CBD oil can significantly improve anxiety. Why don't you try this safe dose that we did, the phase, whatever, this is the safe dose. Try it in your 3 patients and give us the data. We'll write a case report. We'll present it to the government. We'll say, hey, this needs to get on the PBS because, kids with severe, depression and suicidal ideation can have a very safe treatment instead of a tranquilizer. But there isn't that process.
Yeah, no, absolutely. And I the regulators are always sort of the last ones in that chain to sort of have the final say. But yeah, I do just recall, some of the work that Mind Medicine and others have been doing in lobbying for regulatory changes fell short not that long ago in seeking a down schedule. But I'm sure that decision will be mooted and revisited now that we have a new federal government. So fingers crossed for, patient access to psychedelic medicine. It's certainly a topic we're pretty interested in following along on this podcast. But yeah, just jumping back to cannabis. So what are in terms of, because we might have, I know some of our listeners might have been prescribed medical cannabis for anxiety or other mental health conditions, but what are some of the things that as a doctor you have to consider when you're prescribing cannabis for a mental health condition? And I know that's very broad because it depends on the condition, I'm sure, but yeah, what are some general points?
Firstly, you want to know, is the patient stable or unstable? What does that mean? Does that mean, are they, do they have suicidal thoughts? Are they seeing things that aren't there? Is there a history of psychosis? All of that. And that's, the pointy end, but it's not the majority of patients. Once that's kind of ruled out, you want to know that they've got good lung function, all of that stuff. So basically, other than that, so you asked a few things. So your question is, how does a doctor assess a patient?
Yeah, and like just on that first point about whether they might be, in a critical state, and needing acute care, what does that look like from the prescriber's perspective? Do you just, is it a no-go for that person to have medical cannabis? What's your sort of...
Depends on the condition, right? So, and it depends if the patient's, cannabis experienced or not. So yeah. Let's go through an example. So this is, a similar example of a patient demographic that I come across. So you've got a 40-year-old man who has, for the last 3-4 months, suffered what we would medically call melancholic depression. Okay, that's when the brain slows down. This person can't get out of bed. They wake up with tightness in their chest, dry mouth, and they just want to cry. They don't see any reason to live. There's nothing they would enjoy. They stop eating. They lose weight because, they have no interest in eating. They have cognitive dysfunction. They can't even read a page on a book, right? So this patient comes and says, doc, I've been using cannabis in the past, and sometimes when it gets really bad, I have a little bit of THC. And what does that do for you? Well, it allows me to actually get out of bed and have breakfast. And when I hear that as a doctor, then I would say, well, isn't that a good treatment?
Yeah, absolutely.
You've had no side effects. You've tried this before coming to me. I can give you a therapy that you and I agree know works, and I can make it safer for you. Right? Yeah. So in that situation, it's easy because as a patient who has some experience and is telling me that there's been an improvement, and I can walk them through how to do that safely. And because they've come to me now, I can obviously do all the other stuff like the blood test, the psychotherapy, all that stuff. Some other patients that I find really have benefited are my trauma patients, right? So yeah, so often, for instance, like for example, young 40-year-old lady with a history of severe anxiety, unable to leave the house, right? Delving deep into that story, sexually abused as a child, right? And what happens in trauma, and particularly people who've gone through childhood abuse, is that it's almost as if the past is dragging them back, right? They can't actually live in the current moment. So they could, they might have a nice job, they might have a family, they might have a house, but every day they're waking up and they're remembering, either they're getting flashbacks or they're feeling those emotions of, I'm not going to make it out of here, I'm not going to survive. And what I found that cannabis really does, and I don't fully understand how it does this, but what I feel like it does is it almost dampens the stress response in the amygdala and the emotional centers in the brain. And once that traumatic emotion is lessened, I feel like what I'm witnessing is patients are able to access higher consciousness. And what that really is your cortex, right? We know when you get angry or upset, you can't think clearly. You can't use your higher functions. And so what I have found really useful for a lot of patients who've had childhood abuse is cannabis-assisted therapy for that. So what they will do is either an oil or CBD or flower, depends on the patient. They'll microdose that. Okay. And then we'll practice some mindfulness. So they'll go and, sit on the beach and just feel the waves, feel the sand, be present in that moment, or they'll journal, or they'll listen to music. And over time, what happens is it's like they've rewired their brain to be able to be present and to be able to develop tools to live, with that trauma.
That's amazing.
Very interesting.
Some of the patients.
It almost, that's kind of, that parallels the underlying method of action of how psychedelic medicines work, allowing somebody to actually step away from their trauma to some extent and view it almost in third person and have a break from it. Is that kind of?
Yeah. So there's many parts of ourself and our consciousness, and a lot of people who are psychotherapists will tell you that, for example, when if I'm a patient who's got PTSD and I wake up and I feel I'm going to die, I can't make it, that voice might even just be the voice of that inner child of mine that was abused, that every day felt like they weren't going to make it. But what happened is your brain, their brain cut them off from that trauma so they could survive. So that when they get to adulthood and they are safe, all of those traumatic feelings and emotions then hit them. And that's why people, they drink and they use cannabis for this. People use cannabis for this. We have, lots of data. But what we can do is help them do it properly. I think we're going to finish up soon, but I have an interesting anecdote a patient shared with me actually about a psychedelic trip, which I thought was fascinating. So this was a patient who, lots of abuse growing up from dad, very physically violent, always fell into bad relationships and couldn't understand her own patterns. It was very unclear to her. What she did, so she was in a toxic relationship that she knew was bad for her. We always say, why can't these people leave? And what she did one time is she basically prepared her house. She got some journaling material. She took some mushrooms. And she reports it being the most painful experience of her life. It was almost as if she had this incredible grief and remorse. She felt like it was she said that it was like being punched in the stomach with grief, the worst experience she ever had. And if she was near, a cliff or something at the time, she would have thrown herself off. That's how bad the despair was. And I guess that's an important caution around people. Yes, psychedelics are good, but, it can be deadly, and I wouldn't advocate doing it outside of a clinical setting. But she had done that. And what became clear to her, though, is when she experienced that pain, and then it kind of passed through her. And it became clear to her that what she was trying to do was attach to people because she'd never formed an attachment to her father. And that insight really just, like circumvented years of therapy for someone to get that through their head. So I don't know how psychedelics do that, but that was very interesting for me to hear.
Absolutely. Just inviting, an alternative perspective on self, although self is itself an illusion. But it's fascinating.
Really deep dived here at the end.
All right. No, well, sorry. I mean,
we're all consciousness is one, right?
Yeah, exactly.
Floating soup.
That's
You are me.
The one question I do have out of that is, how do you grapple with, I guess the major thing that we hear out of, the downside, let's say, of cannabis, for example, is its apparent propensity to induce psychosis or, schizophrenia or these types of things. But yet I see cannabis listed as a treatment for schizophrenia and anxiety and paranoia in some scenarios. That's probably the last question I'd have from the doc.
I don't really know if it does, and I don't think anyone can really say that it does, right? Because I think there's too many confounding factors. Just as a clinician, the patients who come to me with heavy history of cannabis use, not doing it because they have a great life and everything's great and they just want to get stoned every day. It's because they've found something that has allowed them to self-medicate severe pain, trauma, low brain chemicals. They're really suffering, right? So when you have a population that already has all of those things and then they're using cannabis, like how do you separate it out? So look, does cannabis cause psychosis? Maybe it does, maybe it doesn't. One of the most common skin treatments we give to teenagers, Roaccutane for acne, can cause psychosis. So lots of things can cause that. I don't know how important that question is. I think what's important is, what do we do for people who suffer a psychotic mental illness? And how do we research cannabis more to make it safe for them? Because now we can use cannabis in a more sophisticated way. And we're seeing the benefit in mental illness. And how do we not leave out people who have bipolar and schizophrenia and really need more new therapies than anyone else, right?
Absolutely.
My theory on psychosis, from a few things I've read, is that, especially in children, it seems like the brain is almost creating some sort of endogenous chemical to provide an internal anesthetic from pain, right? It's very interesting when you see people who have become psychotic, especially if they've had a depression that's developed into a psychotic depression. And there's my son. So I think that's the end of that. But anyway, it was so nice riffing with you guys. I really enjoyed it.
No, thank you, the Cheems. We're very grateful for all of your insights, and really, I feel like we could chat for hours, but won't hold you up from attending to mum duties.
So thank you very much for your wisdom, and I'm sure maybe we'll get you back on the show in another time, but otherwise I'll just be speaking to you generally.
I just want to say, I think we're really at a really important point in time for mental illness. We've got exciting therapies. We're seeing people really suffer, and I think we really need to come together on this, and it's something that everybody suffers from. And I think we really need to come together and push through as much as we can, and really have the courage to be innovative for our kids. If we're not going to come up with better treatments now, then when is it going to happen?
Exactly. They'll just inherit the same system we're all living under now. So it's time for people to, be bold, be brave, and actually, open up this world of medicine to the next generation, and us, of course.
Beautifully said, guys.
Excellent. All right. Thanks so much, the Cheems. We'll speak soon.
See ya. Thanks.